been working on she has been working on educating professionals and patients on the importance of the incorporation of tobacco treatment and mental health and substance abuse treatment. Ms. Molly Leese.
Good afternoon. Thank you for that wonderful introduction. We want to talk a little bit about, to follow up with Paul's great presentation on some of the statistics, just some of the incidents with polysubstance use and some interactions between drugs of abuse, and then also some treatment strategies that we can look at. All right, so what are the factors? It's recognized that about 80% of nicotine-dependent smokers start during the teen years. And many people aren't just using that one drug, but many other drugs with it. So with marijuana, some of the factors are that, if I can switch these slides. Wait. Hold on. Yep, I might need some help. Yeah. There we go. Just tap this one. All right, technical. All right, so some of the factors that we're looking at are that increased medical and recreational legalization. People's perception, like Paul had just said, is changing, and people are regarding marijuana as not very harmful anymore, legalizing it recreationally. For a majority of Americans, they think it's less risky. Users of opiates, as far as an opiate agonist, as far as methadone and buprenorphine, people have the highest smoking rates, more than 85%. And also more than 80% of people who smoke also use cocaine. Well, I'm saying that wrong. 80% of people who use cocaine are also using tobacco. So what we want to understand is, how are these interrelated? And I know that no college student here wants to admit that they're still an adolescent, but the brain does keep developing until age 25. So this makes it a really vital time for growth and connection. And a person can be regarded as either a high risk taker or a low risk taker, depending on genetics. And a narcotic drug that's introduced is going to affect those decision making and decrease inhibitions, and it's going to increase those risk-taking behaviors. So these behaviors in turn then modify the structure and functioning of the brain. So nicotine doesn't have to be the gateway drug. Studies show that the narcotic drug can prime the brain to be more vulnerable to addiction. So the young brain is actually more uniquely vulnerable to the effects of nicotine. It affects it stronger and more rapidly. So the adolescent's brains ramp up and down the dopamine levels. The receptors are going much faster. And because of the immaturity of those brain cells, the brain is still coding. Okay. So when you have these increased number of cells, there's higher levels of dopamine circulating in that prefrontal cortex, but the dopamine levels in that reward center of brain, the nucleus accumbens, are changing throughout the adolescence. And these changes suggest that the adolescent requires more excitement and stimulation to achieve that same level of pleasure as an adult does. And this can make them uniquely more vulnerable to high risk and addiction behaviors, even with a minimal exposure. So kids do not need as much nicotine or narcotic drug to become addicted or be at high risk of addiction. So the combined use with young people can impact that vulnerability to other substance use. And that substance use at an early age can lead to developmental changes in the neurocircuitry responsible for cognitive processes. And what we found out is that nicotine can mask these impairments. So the risk of a young person using any substance of abuse is high risk, and it's also messing with that development and that neurocircuitry. And it's also putting them at risk for mental health issues. But if you're using nicotine, it can mask the cognitive issues, and we might not know that until it's too late. Oh, okay. All right. So with drugs of abuse, you can see, I hope you can see these okay. Okay. Yes. With drugs of abuse, you can see that the dopamine is released at much higher levels than the brain is meant for. With alcohol, the dopamine is released at ranges of about 100 units to about 200, and you get a similar magnitude of effect with nicotine. And as you can see, nicotine sometimes is even releasing more dopamine than alcohol. Cocaine produces a very large amount of dopamine, more than the 350 units. Methamphetamine, you can see on the one slide, you can get up to about 1,200 or more units of dopamine. So when you're taking in cocaine, the only effect cocaine has is to sit on these reuptake pumps and block them. The dopamine accumulates in the synapse, and it causes the cell to fire and fire way longer than is what is supposed to. And the dopamine is not being pulled out of the synapse. And so the cocaine will sit here and cause a big accumulation of dopamine and extended feeling of pleasure. Methamphetamine takes it a step further. It can sit here for 8 to 12 hours, causing a big buildup of dopamine for a much longer period. So you feel these extended feelings of pleasure for a much longer period of time. Plus the methamphetamine is actually taken into the terminal and destroying the nerve terminals. So you can see that withdrawal and tolerance effects can be quite pronounced when you're dealing with these chemical changes. Okay, there we go. So in briefly looking at some of the specific drugs and how smoking affects them, nicotine and alcohol go hand in hand. Even people who are not daily smokers might smoke when they drink alcohol. Nicotine and alcohol enhance each other, and the lack of one can increase the cravings for another. So first, the nicotine intake through the smoking enhances that positive subjective or discriminative stimulus effects at low alcohol levels. But however, as more alcohol is consumed, the effects of nicotine become less apparent, leading to increased cigarette smoking. So we have a back and forth effect, and so people will smoke and they'll feel better high, they'll take in alcohol, they'll feel even higher, they have to take in more nicotine to feel even better, and thus the pattern goes. But also nicotine helps alleviate withdrawal symptoms from alcohol as well. There we go. Oops. I gotta go back. There we go. All right, so with opiates, we have a little bit of a conundrum with opiates, because what treats opioid use disorder best when you're using medications is things like Suboxone and methadone. But actually nicotine increases cravings for, nicotine cravings are increased and people smoke more after they are using things like Suboxone and methadone for the alleviation of the opioid withdrawal. The nicotine and opiates produce a cross tolerance or a cross sensitization, such like so exposure to one drug increases or decreases the response to another. Chronic pain is also implicated in the co-use of tobacco and opioids. So paradoxically, nicotine use is known to have short-term analgesic effects, but ongoing use leads to chronic pain. So nicotine initially releases these endogenous opioids and starts opioid-induced pain blockage and activates the pain inhibitory pathways in the spinal cord. And the chronic nicotine exposure leads to tolerance in this analgesic effect. So nicotine, or perhaps another component in the tobacco smoke, may sensitize the pain receptors, decrease that pain tolerance, and increase that pain awareness. So smoking could be a factor in the onset or exacerbation of arthritis, sciatica, fibromyalgia, and chronic headaches. Now, with stimulants, cocaine use, we know, can increase smoking, and smoking can increase the severity of cocaine. Cocaine-dependent smokers use more cocaine than cocaine-dependent non-smokers, and the rate of cigarette smoking increases during bouts of cocaine use. The clinical studies have found that concurrent use of nicotine and cocaine enhances the drugs, and the users report that nicotine enhances the reinforcing effects of cocaine. So using nicotine prior to cocaine has been shown to accelerate the acquisition and increase the overall levels of intake of both cocaine and amphetamines. So most cocaine users will admit that they use nicotine to increase their mental concentration and help them feel better physically. So it may alleviate some of the adverse consequences of chronic stimulant use as well. All right, now cannabis. Nicotine is classified as a stimulant drug, and marijuana is a drug that can posit 3 different classifications. It's generally classified as a depressant with hallucinogenic and stimulant properties. The endocannabinoid system enhances the reinforcing effects of nicotine for enhanced pleasurable experience and increases the probability of one substance prompting initiation or an interfering with the cessation of others. So co-users who present for cannabis treatment can have more severe cannabis use if they're using the nicotine. They can have greater withdrawal symptoms, smoke more cigarettes, and have a higher dependence on nicotine. So nicotine also can help alleviate withdrawal from cannabis as well. So as nicotine can be more addictive than cannabis, tobacco use might be the primary driver of continued use and relapse in the codependent users. The method of mixing tobacco and cannabis together has been demonstrated to increase the THC inhaled per gram by as much as 45%. And usually what happens is people will use smoking tobacco after the use of cannabis because it results in an enhanced high and a longer high. Also, acute nicotine and cannabis appear to exert opposite effects on cognition. So while nicotine increases your arousal and improves your attentiveness and cognition, cannabis induces difficulties in concentration and impairs the performance on learning and memory tasks. So they might be using these as well to neutralize those cognitive functions to a state of equilibrium. Tobacco use can also complicate your psychiatric treatment. So there's components of the tobacco smoke that can interfere with the metabolism of certain medications, resulting in lowered blood levels and probably reduced therapeutic benefit. Some of the ones that when we teach people as tobacco treatment specialists, we want to make sure that we get people to understand is injectable insulin is a big one. Caffeine. People can usually take in much less caffeine after they stop smoking because it's actually going to work a little bit better. Birth control, and we talked a little bit about methadone and also clozapine as well. There's a whole list that you can find too of medications that after people stop smoking actually might work a little bit better. So in looking at withdrawal, withdrawing from nicotine and other drugs at the same time is going to be like an extra intensified breakup. With all these drugs of abuse, there's characteristics of the withdrawal that are going to be intensified if you're withdrawing, especially from multiple drugs. I was just in the psychiatric unit a few weeks ago trying to help somebody with smoking. The physicians kept taking away nicotine from her. She was withdrawing from cannabis at the same time, and she was very upset. She was disruptive. she was angry, and they didn't put the nicotine consult in until about 2 days before she was leaving. And when I talked to her about, quitting smoking, and she told me all of this, and she was a 2-pack a day smoker, she's like, I would have not probably felt this bad if I would have at least had something on board to take care of some of this withdrawal after she understood what was really happening. So the key is that we have to manage these withdrawal symptoms to help people to be able to have a chance at even ceasing the use of these drugs. So in briefly talking about the mental health associations with tobacco, though, it's important to understand what needs to be addressed. The prevalence of those reporting mental health disorders among co-users is higher than single users. And then people with panic disorder and anxiety issues self-report more severe symptoms than those who are non-smokers. So some of the medical issues can raise your anxiety levels, and smoking can produce bodily changes such as blood pressure, adrenaline, and respiratory rates that can bring on fear and anxiety. Withdrawal symptoms is a big factor in producing anxiety symptoms. And also when people are relying on the smoking to deal with some of their coping mechanisms, and then it's taken away, and they have no other coping skills to help them with this, it's going to be a big risk factor in going back to smoking. And it's also going to raise some anxiety, feeling like they don't have anything, and it can bring on some panic. So with depression, there's often a masking of depression. And I think Paul alluded to this earlier too. Self-medicating the depression, what comes first? Tobacco changes the neurophysiology of the brain, and we know this. And so it makes a person very uniquely vulnerable to developing depression. Smoking is a big factor in making the brain more vulnerable to developing the depression, but also depression could be present, and they're self-medicating this with another narcotic drug. Highly nicotine dependent people have more profound and protracted withdrawal, and which can mimic or possibly lead to depression as well. With bipolar, it's very, very important that people are adequately given the right amount of nicotine replacement, because it can increase the mania and hypomania, and it can lead to rapid cycling. So that's very important. So with e-cigarettes, vaping is significantly associated with higher levels of ADHD symptoms based on a 2019 study of college students. Using e-cigarettes, you have nearly twice the odds of associating with cognitive complaints, serious difficulty with concentration, remembering, or making decisions. And you have a higher frequency of depressive symptoms even a year later. There are higher odds of reporting at least one day of poor mental health in the past month. There's trace metals that are found in the e-cigarettes that could be linked to depression. And vaping doubles the odds of having that diagnosis of depression. The good news is that stopping smoking improves mental health. And we know that there's been consistent evidence across the board that it's associated with the improvements of depression, anxiety, stress, psychological quality of life. And you can see the number of studies that have been done, and the magnitude of the effects of stopping smoking were equal to that of an antidepressant. I tell people, do not stop your antidepressants just because you are stopping smoking. But with the interaction of some of the antidepressants with the tobacco smoke, they could work better. The doses could be adjusted, and that's why, the wraparound care of, making sure that people are connected with their physicians is vital. So similarly, there's emerging evidence that stopping vaping has the same effects as stopping smoking. 90% of those who quit vaping reported that they felt less stressed, anxious, and depressed. 47% reported that when they quit vaping, they felt more in control. And 78% reported that they did not quit, but they would feel better about themselves if they had. So when I work with younger people on stopping vaping, almost always when they come in, their mood is very low, depressed, their affect is sullen, they report low energy, they can't do their sports, they're really struggling. And after a couple of months of working with them, I see such a huge improvement in their mood. They're smiling, they can breathe better, they're performing well in sports. One girl said that her soccer coach noticed a huge difference. And I said, what did you say? What did you say? Or what did he say to you? And he just said, well, he thought it was him. He thought it was his coaching. That because she couldn't tell him that she was vaping or she'd get kicked off the team. So I said, all right, you can just let him believe that. So this is also, we know that patients who are treated simultaneously for drugs of abuse have a better outcome for recovery. 25 to 50% in studies usually increase. There's one study that followed people for 9 years, and when they were getting off of everything, there's a significant outcome of they had better recovery rates and able to stay sober. Some of the treatment concerns of co-use and poly-use, it's multifactorial, and from what Paul was talking about earlier, this is a complicated situation. It's going to take some hard work and motivation on the part of the patient. It can be complicated by the mental health issues if they're not being treated simultaneously. Nicotine appears to interact with these drugs in several ways. It can increase dopamine levels through that nicotine acetylcholine receptor activation. And it's likely the common mechanism through which nicotine exposure alters that rewarding or reinforcing effect of the drug. It produces different behavioral effects, each of those which may be differentially relevant for the various drug classes. And nicotine enhances the effects of the conditioned stimuli that plays a major role in maintaining tobacco addiction and possibly the polysubstance abuse. Also, this is my last drug. How am I supposed to give up this last drug? Many will not admit that they use any other drug when they come through to see for tobacco cessation. We find out, well, I smoke weed occasionally. Well, it's maybe nightly. Well, I just take one hit. I just need to go to sleep. But 50 to 60% of people report increasing the other drug of abuse if they are only trying to quit one at a time. So some of the counseling strategies, some of the behavioral strategies that we might use is evidence has shown, and this is commonly known, there's no impact on the outcome of drug treatment if nicotine, tobacco use is addressed at the same time. So if you're treating tobacco use at the same time as a cocaine addiction, there's no impact on that. It doesn't make the treatment outcomes for the cocaine cessation any different. Studies have also shown that tobacco users with mental health issues require longer treatment and more involved treatment. Looking at the demographics of somebody is essential. Do they live in a legalized state? Do you have access to these drugs? Do you have support? Do you live with smokers? Do you live with cannabis users? Do you live with alcohol users? Mental health issues, are they untreated? But there's not just one type of co-users. There's several different types of users. So you might be a heavy tobacco smoker, light alcohol user, a light cannabis user, use on the weekends, but a heavy tobacco smoker. But so we want to look at the different subtypes of how are they using these drugs. Also, looking at what are their interests in quitting. Why do you want to quit? What are your reasons for quitting? And then looking at what does reward look like to you? Look at the impulsivity issues and what do you need to do to decrease that access? Treatment needs to consider personalized strategies depending on how related the substances are. And I think this is a key point in looking at polysubstance use, is how interrelated are these substances. If these substances are highly interrelated, if we don't treat all the drugs at the same time, the success is not going to look the same. So what I mean by interrelated is I need these drugs to enhance each other. I use them to enhance the high. I need them to go to sleep. I need both of these. I use these both at the same time or in close proximity to each other. If they're unrelated, say I'm a daily tobacco user, I smoke cannabis on some weekends, maybe only with a certain friend, totally unrelated use strategies. So when you're working to decouple the co-use to avoid that shared vulnerability, address the factors of how those two drugs interact. If you're stopping one, it could increase the cravings for another one. All right. So with here's some specifics of some treatment strategies. Looking at harm reduction. Okay, so this is a hot topic right now with harm reduction. As an alcohol and drug counselor, it's abstinence, abstinence, abstinence. And what we're now looking at is, with some of the co-use and poly use, we may need to start looking at some harm reduction. And especially with the legalized marijuana and the medical marijuana, we really have to take a hard look at and what are people willing to do too. So we know we can't force people to stop the use of drugs. They have to be willing to take that action. So our job is to ask them questions. What are your thoughts and feelings about this? What do you like about this drug? What do you not like about this drug? How is this drug affecting you? And so when we're looking at the harm reduction piece, the route of administration risk, especially for smoking cannabis related to smoking tobacco or vaping, that hand-to-mouth action, that's a huge risk for relapse, and that's what they've found. So even if they have to eat an edible or a gummy or something like that, it's going to at least take that down. They're not getting the carbon monoxide. They're not getting some of those issues. And then being able to work with this person longer term to address, how is that working for you? Is this working for you? Are you able to maintain? Are there still some problems? So that would be the goal, but you're aligning with the patient and you're also letting them choose, and you're not telling them what to do, which you might have better outcomes that way. Contingency management is one that I really like too. We all like getting rewards. I like getting rewards, and it has been shown to help in a lot of addiction situations. Even with tobacco, they've done some studies with contingency management and having those milestones to reach, but making sure that the reward is something that the patient actually wants. So $25 if you come in and you test and and you can do these milestones and get money for it. Some people continue to stay quit because they've got some time under their belt for that. Oh yeah, I think that was about it. But also looking at just some of the nicotine replacement, we really want to make sure that people are well managed with nicotine replacement. I heard that with the ETU that goes around and gives out nicotine replacement here on campus. I think that's amazing. And if I could do that at Mayo Clinic, I would totally do that with everyone. I think we should do it, because when people can just have a chance to try it and just see how it feels, and then we can follow up with them, it makes their chances of quitting so much higher, because then at least they have a chance to look at this and say, oh, this isn't as bad as I thought it was going to be. So with that being said, I'm wondering if there's any questions. I'm open for questions if anybody has any.
Thank you, Molly. Excellent job. Thank you so much. So we are going to ask questions. Looks like we have some in the room, and I can't see if we have any in the chat. Yes, maybe.
Hi, I had one question. So earlier in your presentation, you talked about opiates and tobacco.
Yeah.
I was just wondering, since tobacco can increase that high or it can decrease the effects of the pain, after those effects are done, does that make the person want to increase their opiate dosage? And does that have any effect on overdosing?
Yeah, good question. So with the nicotine use, yeah, it definitely increases. The nicotine use increases after the opiate is used. Is that what you're asking? Yeah. Yeah, they go back and forth like that. Yes, for sure. And that's what the problem has been. But even with people who are on opiate replacement, like so Suboxone and methadone, the smoking has increased because the cravings are increasing. And so that becomes a problem. There has been some studies with naltrexone, which has been shown to decrease opiate and cigarette cravings, which could be a possibility, but also managing people with nicotine replacement, as well as the opiate blockers to see if that would work. But working closely with them is key. Yeah.
Other questions for Molly, either online or here in the room? Oh, Kevin.
Thank you for your presentation. You really helped me understand polysubstance use a little bit better, because it turns out it looks like nicotine can help avoid some withdrawal from certain drugs, or it can sort of accent or enhance a high with other drugs. And so it helps me be able to talk to a patient or a client, because I'm going to understand why they're doing it and not just think this is somebody who's just trying to throw as much drug into their system as possible to see what happens. It's probably purposeful. And then my mate, so one is thank you for kind of helping me clarify that. And the other is a little bit more about harm reduction. In general, I know it's controversial. And just wanted to hear a few more thoughts from you about that, as those of us who work in the field trying to get our heads around that concept.
Yes, thanks. Yeah, harm reduction, right? And being in the field, it's abstinence is the only way, right? But more and more, if you're able to work with a patient or a person longer term and get them to reduce. So tobacco, notoriously, we have done cut down to quit. And some people really want to do it that way. They want to cut down to quit. And some people can. 5 cigarettes or so, 4 to 5 cigarettes is about the minimum amount of nicotine that you need to avoid the major withdrawal. So when people a lot of people can get down to about 4 or 5 on their own, and then they really struggle with those last 5. So sometimes then we can intervene and start to say, okay, let's be a little bit more aggressive with that if you need help with that. But then, the things like edibles and medical marijuana, with the Americans' perception that it's not risky. And that can be really tough. I really need this. I need this for anxiety. I need this. It really helps me. But when we look at addiction as a whole, what addiction is doing is you have to look at the route of administration. So any drug that hijacks the brain in very high levels very fast is going to be more addictive. So when we're looking at even narcotic drugs that are given very low and slow, like it has to de-hijack, if that's a word, the brain eventually. So you're helping bring it down. And so, and you're giving it much lower doses, much more even. And so that gap in between where it's called the hedonic system, that becomes a little bit smaller. If we can get rid of all the narcotic drugs, that would be great. But we're looking at this multifactorial thing where there could be mental health issues, ADHD, things like that. ADHD, you don't produce enough dopamine to begin with, depression, the chemicals are not producing the way they're supposed to. So kind of looking at this, like, let's work together to figure this out. And that's where the longer term treatment and then the harm reduction really works. Like if you just say, yeah, gummies are okay, and then you never follow up again, it's not going to really work.
Molly, thank you so much. So first I want to say there's a lot of messages in the chat box, more from the clinical side of people who are watching, that you really provided a space that the session so far hadn't. And so thank you for that. And, in this space, it's hard to get all the different topics that we would all be interested in. And I think that all of us working on college campuses understand that youth and young adults are using multiple substances.
Mm-hmm.
And so we often hear, well, we're addressing the substance of concern. And so I want to hear your thoughts on, where does tobacco fall on that substance of concern? And you kind of shared a little bit about, but in the idea that we silo substances when we treat, and how should we think about that going forward?
Yes. Yeah. And typically tobacco is not considered as problematic as some of the other drugs of abuse, and it's been neglected in treatment centers over the years. Even as an LADC in school, I don't think that we really addressed it all that much. And we know it's like, oh, we'll just deal with that later. But it is so important. And the more that I learn about tobacco and the hijacking of the brain that it does, and how it interacts with all these other drugs, and how it can prevent recovery from other substances, I think it's probably one of the most important drugs that we deal with. I think that, what you're doing here on campus, making it tobacco free, but also providing help and free help, is amazing. And I think that that should be across the board on all campuses. And I think, what other, did I get all of your questions? What other one? Okay. Yes. Yeah. Siloing any substance is never, ever recommended. Treating all of the substances, treating the mental health, treating the origin of that, what is really going on. And, as college students too, helping each other, you guys know, working, how much, so much more than probably some of your friends do. And being able to relay that information. I was able to help one of my daughter's friends at college just over the phone. She couldn't stop vaping. And I said, okay, try this, but she was recognizing that she was really struggling. She couldn't quit, and she was using it for mental health reasons to feel better, but recognized that it was not helping at all. So it's a good work.
So Molly, another question in the chat is about your thoughts on, so somebody who has stopped using combustible tobacco or e-cigarettes, but now are using nicotine replacement therapies and have since gotten addicted to those products, and thoughts on how to deal with that.
Yeah, it's what happens when people say that they're addicted to nicotine replacement products is that they're when you stop using a drug, this is what you've used for coping all along. And so if you're only relying on the nicotine replacement for your coping mechanism, and this is what you've attached as this is the only thing that helps, there's a fear that's associated with getting rid of that nicotine replacement. From a harm reduction standpoint, if it's not causing you harm, the nicotine in and of itself through nicotine replacement is not delivered in high amounts, and it's not delivered quickly. Some people that have been long-term smokers need to use this like gum or lozenges, for the rest of their life to prevent going back, which we say is totally fine. But if some people feel like, I'm chewing 20 pieces of gum a day, I don't like this, I don't like that I'm doing this, then we'll work with them like, okay, let's put a patch on. and like then we'll decouple that, putting that something in your mouth, and now replace that with regular gum or candy or something like that. But anything with addiction is replace, replace, replace. Like when you take something away from the brain feels empty. It's just like when you go on a diet, if you can't, starve yourself, and you have to replace it with something else. And I would say like nicotine replacement is like the apple. It's an apple compared to the apple pie of nicotine, because you're not getting it as high and fast as you want to, but you're getting something.
Good analogy. Another question there is your thoughts about youth in particular using Zen products or, synthetic nicotine to assist with cessation.
Yes, so the Zyn and the On products are not recommended. Those they're salt nic products, and they deliver nicotine very high and fast. And they have not been shown to help with smoking or vaping cessation or chewing cessation. If people are insistent upon them, I say, well, you can try them, but this is what we know, is that they're still highly, highly addictive products. And so most people, if you're working with them long-term and they want to start with this and then go to a nicotine replacement product, okay, as long as there's a plan, but it's not a product that we recommend at all.
Wonderful. Thank you. Any other questions here in the room or online? The question is about VLN King cigarettes to help with cessation.
Velo or
VLN King.
VLN King cigarettes?
Thank
Oh, low. Okay. All right. Yeah. Okay. Thank you. Yes. Yes. Yeah. I got to stay up on these products too. Yeah. So the thing with the low nicotine cigarettes though still is like, so we want to look at that route of administration, and we want to look, smoking anything is going to deliver it quickly. So it's still, even if there's not a lot of nicotine, it's the delivery method that we're looking at, and that keeps the brain hijacked and addicted. So sometimes though, when people vape, if they're vaping an e-liquid that has a lower amount of nicotine than what they would normally smoke, because they're trying to lower their nicotine levels. Many people, they end up vaping all day long and they can't stop vaping because your brain knows how much nicotine it needs in order to feel okay. So they will just keep vaping and vaping and vaping, and they're finding that that's all they do all day long because they're just trying to chase that high all day. So I say like, that's not necessarily the best way to do this, but.
Excellent. Thank you again. Anybody else? Final questions? All right, Molly, thank you very much. We really appreciate it.